So we'll be discussing about hip arthroscopy in Indian perspective. So hip arthroscopy, people say that hip pathology is less common in India, that cam and pincer impingement is less common in India. But what we see in hip as an arthroscopist, and we'll discuss into that, okay, what is hip arthroscopy with Indian perspective. If you talk about indications or where to perform an hip arthroscopy, the most common indications are femoroacetabular impingement, that is FAI. Now, it is said that FAI is more common in the Western world and it is less common in Indian population. Probably it is linked to the habit of squatting and sitting down of Indians. So it is said that FAI is relatively less common in Indians because of the squatting and sitting cross-legged habits. But FAI actually, I'll tell you, it is rampant in Western world, so it's very common there. But it is not so that we don't get an FAI in India. So we do get some patients who are suffering from FAI. And they will usually be basically at the pre-arthritic patients. You will see early arthritis of hip. So they are basically the femoroacetabular impingement cases. We will discuss in detail about this. Synovial pathologies are, I think, in India the most common indication when I do a hip arthroscopy. We will come into that also. Ligamentum teres pathologies and ruptures. That is another one important things. You can have loose bodies and chondral lesions, and you can have snapping hip syndromes. So we'll be discussing in detail. Now, because FAI is traditionally thought to be the most common reason for which you want to do arthroscopy, you must understand what is FAI. So FAI is basically femur acetabular impingement. So femur impinges on the acetabulum and that causes restriction of motion, specifically the internal rotation and flexion. Now this impingement can be from the acetabular side or this can be from the femur side. If it is from the acetabular side, it is pincer. If it is from the femoral side, it is cam. So you can have a patient with a pincer impingement, you can have a patient with a cam impingement, and occasionally you will have a combined. So the patient will have both pincer and cam lesion. Now lateral views are again important because on lateral view it will be well appreciated. And the classical location for FAI is an anterolateral aspect. So you need an if you get an X-rays, you need to get a APN lateral, but preferably I recommend a CT scan for exact evaluation, and we'll come to that. Now FAI is about 10 to 15% of population in Western world. Probably it is less in India, but it is higher incidence in athletes, patients who do martial arts and who are doing kick sports. So this is actually important. So this you must be aware of with your hip knowledge, but there are some things that you need to be very careful of, and these X-ray markings are very important. So the first is the LC angle, so lateral central edge angle, and if this is increased, then it is suggestive of a pincer lesion. The second thing is called as a Tönnis angle. So you have a horizontal line which is connecting the heads, and then from the fovea you make another line. So this is the Tönnis angle. So if this is increased, then again you will have a over coverage. So basically pincer is an over coverage lesion. The third is a crossover sign. So if the anterior lip of the acetabulum crosses the posterior lip, that is actually suggestive of a pincer lesion. So this is called as a crossover sign. The third is a posterior wall sign. So the posterior wall is actually medial to the center of the femoral head. That means again that anterior wall is more prominent. And then you have a ischial spine sign. If you have a ischial spine which is visible within the pelvis inlet, they are all the signs of femoroacetabular impingement on basis of plain X-rays. Now labral tear, cartilage lesions and radial reformated. So this is important. So this is a labral tear if you see here. So there is a gap between the labrum and the bone. So that is called as a labral tear. You can have cystic lesion or cartilage lesion here. Now very important thing in hip, you must understand, is hip is the joint in which the per square centimeter loading of the body is maximum. So when the patient is walking, load per square centimeter of cartilage, it is maximum on the hip. So the other weight bearing joints are knee and ankle. Knee is a very broad joint. So the weight is distributed in a large area. Ankle again, it is bigger. So it's a flat sort of a joint. For talus, it's a flat joint. Now for a hip, it's a round joint. So when the patient is walking, the weight will bear on this particular area. So this is the area on which the weight bearing will take place. So it's a very small area where the whole weight bearing is there. And usually if you see the primary arthritis of hip or primary problems, you will have wear and tear in this particular area. So the weight bearing area of the hip is very much smaller as compared to the other joints. And then you can have these lesions like cystic lesions here. So this is a cavern deformity, and beneath this you can see the cystic lesions. Okay. Now treatment of FAI is basically you dissect the cavern lesion, you do osteoplasty, and you do the labral repair. There are three things to the treatment. So you go into the joint like this, you do resection of the cavern lesion like this, then you do resection of the pincer lesion, and then you reattachment of the labrum. So basically these are the parts of the hip arthroscopy that you need to do. Now in Indian perspective, as I told you, synovial pathologies are more common than FAI. You get tuberculosis, which is a unique indication here. And typically if it is an active stage, in early phases, you need to take a biopsy and you need to do a debridement. This is a very good technique. Arthroscopy, you can do an arthroscopy and you can do debridement. That is a good technique. Now what do you need? We were discussing about how I started scopy in India, because initially the instrumentation was not available. So what do you need? So you need to have an OT which has facility of trauma and arthroscopy both. So you need to, I usually do it on a table in which we do a DHS or a PFN. So the same position for the hip. There is a small change, we'll let you know. This is a wide central peroneal post. This is important because if you are doing, say, let's say DHS, you are doing a traction. So you need a longitudinal traction. But here we need a traction in which we distract the joint. So you need a vector here and a vector here. So you need not only a longitudinal distraction but a lateral distraction as well. So there need to be a wide central peroneal post, and you need to actually, so what happens is the hip joint is tightly packed, and if you want to distract it, it is tough. It's a very tough joint. The capsule is also very tough. So as soon as you put the needle into the hip joint, you will see a finding which is called as an air arthrogram. So the air itself will distend the joint. So you put the needle into the joint and you will get a finding which is called as an air arthrogram. So the hip joint sucks the air, environmental air into it. So we'll come to that, I'll show you that. And then you need specific, scopy specific thing, that is the 70-degree scope. You need a long working length instruments. You need a cannulated trocar and cannula. You need half pipes and you need a beaver blade. These are not very technically difficult things, but initially they were unavailable. And we'll see. So these are the two most common positions, supine and lateral. Both are good, but this is more comfortable and user friendly because we are used to it. We all do PF and DHS in this position, so this is more comfortable to us as compared to a lateral position. So we are doing mostly supine position. We use lateral position for some specific indication. I'll let you know. So this is our setup. So if you see, the hip is draped and painted just like you do a PFN. You need to mark the GT, and then you need to mark the ASIS. And from the ASIS, you draw a straight line downwards. And everything which is lateral to that is safe. Medial to that you may get femoral artery, nerve and vessel vein. So medial to that you can feel actually the artery and vein. That is one thing you can mark it. Otherwise a very safe bet is you just mark the ASIS and draw a straight line, and all the portals which are lateral to that and anterior to the GT are safe portals. There is no other important structure which will come in between. Posteriorly, you have a sciatic nerve. So posterolateral portal, you need to be very, very careful, and you have to go very precisely parallel to the posterior part of the GT. Okay, so I'll tell you the things. Now this I was talking about. Can you hear it? Let's show it. So this I was talking about. So this is our Make in India dilator. So these are the things, and these are basically the half pipe that we use. So this is the half pipe. These are the half pipe. These are useful because in hip you cannot use a cannula like you use in shoulder because there is not space, and the most difficult part is to enter into the joint and maintain the scope into the joint. If the scope comes out once, it is very difficult to insert it back because it is the tightest joint of the body. So inserting the joint scope and keeping it there is difficult. Now this is another instrument. This is called as a beaver plate. So this is basically a knife, sharp knife, with which you do the capsulotomy. So with this knife you do the capsulotomy, and this is the dilator. This is basically the dilator. So only you can do it in shoulder also. Some people do it in shoulder also. But what we do is a cannulated entry. You can't like in shoulder and you just pop it into the joint. This is not possible into the hip. So hip you have to do it under the IITB guidance entry, number one, and then you have to have a cannulated system for it. Okay. So this is the dilator I am talking about, and over the dilator we put our scopy sheath. Okay, so I'll just go with the steps. So this is my step. Can you see here? This is what is called as an ear arthrogram. So this is a long spinal leader. So the first step is you put the spinal leader into the hip joint. As soon as you put the hip spinal leader there, you will see a ear arthrogram. This is light here, but this is the ear you can see into the joint. Okay. Once you see the ear arthrogram, you are sure that you are into the joint. It is the first thing, and it will distend also because it is a negative pressure. So it will suck air from in and it will distend a little bit. After that, through that spinal needle, you put one nitinol wire. Okay, and over that you insert this dilator, and over the dilator you insert your cannula, trocar and cannula. Okay, so this you can see air arthrogram better here. Can you appreciate this?
Yes.
Okay, so this is the air arthrogram. So this is the first step. So air arthrogram, getting the air arthrogram is the first key. And now my scope is in. You can see the air arthrogram still, and the scope is in. Okay. And this is again our position. The IITBs will be right there. Now portals, as I told you, ASIs, and you draw a straight line down and keep lateral to that. Don't make any medial portal to that line. That is, if you do that, you are safe. Okay. Now this is your GT. Anterior you have an anterolateral portal, and posterior you have a posterolateral portal. And these two portals are relatively, this portal, posterolateral portal I am telling you, if you go down you may hit the sciatic nerve. So this portal you have to make with a whole lot of caution. Anteriorly in this area you can make as number of portals that will be relatively safe. So anterior portal, mid-anterior portal, anterolateral portal, these are safer areas for making the portals. Now as I told you, this straight line is very important. And then you have a straight line which is connecting this. And approximately just anterior to that is the anterior portal. Now you have a jig available by which you can make the anterior portal and use a jig to make a anterior portal. But usually I make it in a freehand fashion. So this is the dilator I was talking about. So this dilator, this is the needle. So you put the spinal needle, over that you put this nitinol wire, and over the nitinol wire you need to put this dilator. So this is a sequential dilating of the hip portal, and over this dilator you put the cannula sheath, and that way your sheath will be. Still you can damage. So this is such a tight joint. Still, if you follow everything, still you can damage the cartilage, and that damage in cartilage is not well tolerated because it is on the weight bearing area. As I told you, it's a very small area where all of the body weight is there. So you have to be very, very careful. Very important. Another concept is when you insert your first spinal needle, this way. This needle, this is the perfect position of the needle. Sometimes the needle will go here in this area. So sometimes the needle will go in this area. So it may penetrate from the labrum and go into the joint. So, and again you will get an air arthrogram, but if you try to dilate, you will be dilating the labrum, which is not correct. So once you inserted your needle, you get an air arthrogram. You need to check where the needle is captured or not. or if it is very close to the bone, it may be through the labrum, and you can reposition it just beneath the labrum. So we want to go into the capsule, we don't want to go into the labrum. So these are the important technical tips that you want to make. Okay. Now, anterolateral portal is usually the working portal, and the viewing portal, and anterior portal will be the working portal for most of our cases. So as I told you, the lateral femoral cutaneous nerve, femoral artery, vein and nerve. These are the areas at risk, and how to avoid it I have just mentioned. And sciatic nerve posterior. One very important thing. Besides injuring the nerves directly with your instruments, the other mechanism of injury in these cases is neuropraxia due to traction. So that is also very important. So whenever you are doing a hip arthroscopy, always note the traction time. Just like as you note the tunicate time, you have to note the traction time. So the traction time should not exceed more than 1.5 hours. So if it is your surgery is prolonging more than 1 hour, you stop it, or you take you release the traction in between. That is very important. So that is very important. So more than 1.5 hour of traction time, if you can, you may land up into neuropraxias, because it is a traction with an intact limb. It's not like a fracture where the continuity is broken. So there the chances of traction injury is less. Here the chances of traction injury is more, because everything is intact. Okay. Now these are very good indications. Synovial chondromatosis, very good indication for hip arthroscopy. You go into the joint, take out all these loose bodies, the patient will be very, very happy. PVNS, again very good indication. You will get these sort of large synovial fronds here. You remove these synovial fronds, the patient will be very happy. It's much more common than we think. If you start getting hip MRIs, you will get many patients with hip pain with actual synovial masses like this. So this is a live video demonstration. A patient, about 40-year-old, high-profile patient. He has pain in the hip joint, and we have entered the joint with the anterolateral portal, and my instruments are in the anterior working portals. Okay. Now important thing is we need to do a capsulotomy. So you can see a lot of loose bodies there. You can see, and you need to do capsulotomy. So for capsulotomy, you can use your vapor device. That is number one. And you can use your beaver blade. This is my beaver blade, which I have just shown you. That is important. This is the beaver blade we are talking about. This is the beaver blade. With this, you can do a capsulotomy, and you can do a capsulotomy with your RF device. And once you have done the capsulotomy, you will have a space, and then you will do the resection. So this is my bone overgrowth, and I'll be dissecting it with a burr. So the cam lesion is there. So we are resecting the cam lesion here. Okay. So this is called as a cam resection. Osteoplasty. Okay. So once we are done, then we will just see, and we'll see small loose bodies. We'll just take it off if there are any. These are there are two compartments. Will come to that. So this is a capsule. And this is a capsule. You can see the loose bodies coming on from there. This is the inferior capsule. Okay. You can see the loose bodies there. These are all loose bodies into the joint. You need to take them off. Okay. Instrument wise, you need to have a curved shaver blade. A straight shaver blade will not work, will not go in. Okay, because your trajectory is like this. So you need to have a curved shaver blade. So this is a curved shaver blade, if you can just appreciate. So this is a curved shaver blade. This is a posterolateral portal we have made. As I told you, we have to be very careful in putting this portal. And these are again loose bodies. This is almost in the area of the ligament teres. Okay. These are all again loose bodies, small loose bodies, and so you need to take that off. So this is again we are into the posterolateral portal. Curved shaver blade, dissection of the cartilage. You can see the cartilage damage here. Okay, so this cartilage damage has to be addressed. Okay, this is the cartilage area. This is the area of the cartilage which needs to be cleared. Okay. Now, very new concept is arthroscopic assisted co-decompression. You must be doing co-decompression. Co-decompression is very standard surgery, but most of us do the surgery with a drill hole through the neck. And what it does is it may weaken the neck occasionally, and rarely it may cause fractures in the region of neck and the subtrochanteric region. And that is why we need to immobilize this patient and we don't regularly allow them weight bearing immediately. So this is a newer development, very new development, in which so what do you do here?
So initially I get X-ray and if required MRI.
Excellent. So this is the X-ray. Any comments here? First,
Yes, sir.
what will you do?
On that side we can see pincer lesion.
Left side there is femoroacetabular impingement sort of.
So I'll ask for an MRI because there is a lesion in the.
But are you sure it is pincer?
I'll also ask for a lateral view, sir.
Very good.
Yes.
So, are you sure it is pincer?
Could be.
So, pincer lesion is usually bony lesion, and it is actually at this level, and there will be a bony overgrowth. Now, the consistency of this lesion is not that of bone. So, you have seen calcific tendinitis of shoulder.
Yes.
So, basically, it is a calcific deposit on the labrum. It's a calcified lesion in the labrum. Okay, I'll come on to that. So now, if you see, now you can appreciate the consistency of this and consistency of bone. In pincer lesion, you will have the bone itself overgrowth. Now this is pure calcium. You can see.
Yes.
Okay, so you have a calcium deposit which is in the vicinity of the labrum. Okay. So again we went in the same way, everything same, and same as we discussed. This was our intro picture.
We keep leg slightly abducted.
Slightly. So now we are going in again. If you see this was under labrum, so I just manipulated it a little bit so that it goes beneath the labrum. Okay? And then I'm doing my capsulotomy with my RF probe. Okay. We are clearing, rewriting the things. And there, if you can just appreciate, you can start seeing the calcified mass. This one. Okay? And the calcium is coming out. If you have seen calcific tendinitis of shoulder, it is quite similar to that. The calcium starts coming from there. Okay? So the calcium starts coming from there. And we keep on removing it till we are sure. So basically what it was, it is a paralabral calcific cyst. So there was a labral tear, so they form a cyst and it got calcified. So what we did is we did complete removal, we removed everything out of that, and then we put one anchor and repaired the labrum. Okay. So this is the labral tissue, and this is actually the capsulotomy area, and this is the labral area, and this is a penetrating suture grasper. We hold the labrum with the suture, then we cinch it, lock it, and then we put a knotless anchor over there. So we do the labral repair after removal of the calcific tendinitis, calcific lesion. Okay. Now this is a follow. Now this is interesting. 18-year-old young boy, pain in groin, difficulty in walking, limb, painful IR and flexion of the hip. Next step, Kaustubh.
Plain X-ray.
So this is the plain X-ray. Any comments? CT is also there. Any comments here? So it's a large cannulation. For 18-year-old boy, it's a very large cannulation. IR pain. And these patients will have pain in the groin. So that's how you differentiate between a hip pathology and a back pathology or some other pathology. They will have classical pain in the groin. You can see cam here, okay. Spiky cam here, spiky cam here. So big lesion. So you have a predominant cam lesion. This is a pincer, but that is not important. This is a little bit of labral there. So the plan is by and large a cam dissection, if needed, limb trimming and labral treatment. Okay. So this is our plan. This is how we did it. And this is our post-op view. So we dissected the cam like that. You can see that area we have dissected the cam, post-op. This is the post-op region. And this is the post-op CT. If you can appreciate this area and this area we have dissected about the mode of cam. Okay. And this is his movement at 3 months. So gained good movements. So impingement which was there is now gone. Now 40-year-old male patient, pain in the groin, catching and locking sensation, pain on a particular flexion and internal rotation angle. Okay? Pain on a particular flexion and internal rotation. So if you want to do a particular movement, he had got sharp pain. Okay? This is the lesion. This is the MRI pictures. Any comments? This is the femur, acetabulum. Can you see here something?
Yes. Cystic lesion.
It's not a cyst. It's a mass lesion.
Mass lesion.
It's a mass effect basically, and it's a catching locking sort of a sensation the patient was having. Okay, so it's a sort of a solid mass which is there intra-articularly. Okay. So this was the lesion, and we take it off en masse. It was PVNS. Biopsy. Okay. This is another common scenario in India. Post hip dislocation, the hip is reduced. There was hip dislocation, the surgeon reduced the hip. There was an eccentric reduction after the reduction, and there is a small loose body which is inside the hip joint. Yes. And then we can remove it with the hip scope. Now this is a gynecologist. She is the mother of an orthopedic surgeon. 58-year-old, very active. She is a cyclist, she is a marathon runner, everything. Okay? And she has pain on the right sided area, this area. This area. Okay. GT. Trochanteric bursitis, diagnosis trochanteric bursitis, given a lot of conservative trials, multiple opinion, around 10 to 15 trials. Okay. What is it? Anything you can see or anything you can
Hyperintense signals is involved
in the
medius and vastus laterales.
very good. So
How much?
what is it?
Is it that
She is a cyclist and she is unable to cycle. This is one of her main symptoms.
How much?
Huh?
How much sort of means?
Can you see something here? It's marked also. What is attached on GP?
origin of vastus lateralis and then gluteus medius?
Exactly. So if you see this black line is gluteus medius, and you can see the insertional tear of the gluteus medius.
Yes.
So there is a small tear, but gluteus medius tear, and that's why she was not able to. She was very specific. Pain here, pain here, pain here, and she is not able to do her high level activity. She was a very active lady. So gluteus medius and minimus are called as a rotator cuff of the hip. Okay, so the symptom and the mechanism injury is similar to the hip rotator cuff tear of the shoulder. So it's a same like that. So the incidence is common, but historically presumed GT pain was solely due to bursitis, and it is more common in females. So there are 4 facets: gluteus medius insert on the superior posterior facet and the lateral facet, and the gluteus medius insert on the anterior facet. So you must be doing a lot of hip surgeries, hip replacements. So what you do is you spare it. If you are doing a posterior approach or posterior lateral approach, you don't touch the gluteus medius and minimus, and you will go posterior to them. You spare them. Anybody of you is doing anterolateral approach to the hip totally? So why is it not popular? Why it is not popular? It's an easy approach, straightforward approach, but why it is not performed commonly?
We Abductors.
Exactly, you get abductor lurch.
Lurch.
So what you need to do is you need to dissect the gluteus medius and minimus complex, and then you have to anteriorly dislocate the hip for doing that surgery. And after the surgery, you need to do a very meticulous closure of the abductors. And if you don't do that, you will have an abductor lurch. So that is why this anterolateral approach has not become popular. So when I was a fellow, one of my attendings used to do this anterolateral approach for hip replacements, and he focused a lot on post-op repair of the gluteus medius and minimus after doing a arthroplasty. So that is very important. So this is the area. So this is the area where these are basically the balancers. So if they are not there, the patient will have a abductor tendon kind sort of a lurch. So this is more commonly degenerative as compared to acute traumatic. So you may not get a traumatic history every time. It can be partial, complete, or intra-substance. It is basically a dull and aching pain on the lateral aspect of the hip, and it is tender to palpation. You will have a restricted hip abduction and pendular kick. So pedic trochanteric, you need to you can have a bursal thickening, edema, insertion, tendinopathy and tear. So treatment options, conservative, resistant cases, you can be an open repair or an arthroscopic repair. Then you can do a transosseous or an anchor repair similar to your cuff. So portals, again you can do this search in supine as well as lateral. As I told you, is more common. The position might have more comfortable in supine. So you debride the footprint and then you can just put the sutures and repair it. So here this is the bare area of the gluteus medius. So we insert one anchor here. So you will feel it much similar to your cuff repairs. So you put your anchor there. You put your anchor, you take it off and put it back. Okay, so this is my first step. After that, we'll put the anchor there. Okay, this is the GT, this is the facet basically. We'll put the anchor. Okay, so you can put your anchor. And then after that, you can put your sutures through the torn area of the tendon and then repair it as you do it in your. So and then sutures are there from the, and then you just take out the suture and use your suture passing device that you use for cuff to pass them sequentially. So this is the intact portion of the tendon. This is the torn portion. And you can use multiple suture passes. So you can see this is the cuff, this is basically the area of the gluteus medius, this is the anchor, and you can use any number of passers like you are using a bird beak here or a 6-stitch suture passer to pass the sutures through the gluteus medius and repair. This is as simple as any cuff. Post-op rehabilitation is simple. Thank you.